Hi, I'm Sam. Today we'll be talking about shoulder dystocia and managing a birth from the second stage of labour right through to the delivery of the placenta. When we go to an obstetric patient who is in labour, it's unlikely that we will know if shoulder dystocia is going to occur just due to its highly unpredictable nature. The baby is generally in the right position and that's shown on the scans that the mother does have. It does occur in about 0.15 to 2% of the general population because of some risk factors, which could be gestational diabetes leading to a bigger baby, so fetal macrosomia. You could also have just the anatomical shape of the mother's pelvis as well, could lead to the baby getting stuck on the pubic symphysis. When we go to a woman who is in labour, how to kind of determine whether the birth is going to be imminent, we look for a couple of signs. So is the contractions 2 minutes apart? So is she having 5 contractions in 10 minutes? Does she have any starring of the anus? Is there any bulging of the perineum? Have the waters broken? Is there any kind of urge to push? If any of these signs are there, then you're kind of preparing for an imminent delivery and should stay. Then we would move on, prepare for a normal cephalic delivery, where you'd have just general, because we're not sure what's happening in the pre-hospital world, you'd have like an airway kit and a resuscitation kit, just in case the baby needed to have any resuscitation afterwards. As mentioned previously, we prepare for a normal birth, so contractions are occurring, the mother is pushing. We see that head is starting to come out here. Oh, there it is, and then it's out. Okay, but we don't see any further movement. The head actually retracts a little bit, so if you just want to keep just pushing and kind of pulling back just to demonstrate that bobbing, so push a bit more, a bit more. There you go, head's out, and then back just there. No, that's too much, there you go. Perfect. Alrighty, that's known as turtle sign. When we see this bobbing, that generally indicates that the baby is having a bit of difficulty moving through the birth canal. And this could mean that the anterior shoulder is just stuck behind the pubic symphysis here, so right about this position. There are a couple of manoeuvres we do to try and rectify this position. We start off with some external manoeuvres before moving on to internal manoeuvres if no change in the baby's condition has occurred. So the first external maneuver we do is McRoberts position, and that involves getting the mother to moving the mother's knees all the way back towards her ears. Generally, we'll have one birth assistant here getting ready to help deliver that baby, and having another paramedic or another person on scene just hold those knees like so, all the way back to the chest. And these maneuvers should occur while the mother is having her contractions. And it should last about 30 to 60 seconds. We don't want to make any maneuver too long. So McRoberts maneuver, knees to the chest like so. You don't want to cause the mother any other injury as well by stretching something you shouldn't stretch too far. So it's kind of a little bit of discomfort you're going to cause, but not more than what's happening down here. So this position will last for about 30 seconds, and hopefully we'll see some improvement in the situation. If not, then we move on to what's known as Rubens 1, which is suprapubic pressure. Okay, as the baby is facing this way, we want to come around this. So we want to put pressure while the mother is in the McRoberts position. We want to put pressure just above this pubic symphysis right here, and careful not to put any pressure on the fundus or the uterus itself, because that can involve some uterine injury and lead to some PPH, which we want to avoid. So pressure here just above, you're trying to dislodge that anterior shoulder. With this, when you're doing the pressure, you can also have some rocking movement in there. So you just want to try and dislodge that shoulder. So as you can see, the shoulder is coming out, maybe just like that. Yeah, keep going. Oh, perfect. Generally as well, with most cases, this shoulder dystocia does resolve post doing some suprapubic pressure and the McRoberts position. If unfortunately that's not the case and shoulder dystocia is not resolving, you're still seeing the bobbing, it's not actually progressing any further, then we can move on to a different position. Another external maneuver we'd like to do is the Gaskins maneuver or the all fours maneuver. So we'll just try to do this with this mannequin. We want to get the mother. It is a bit difficult. We want to try to do it in between her contractions. And also she could be tired depending on the position she's in. That might not be a good idea. But generally the Gaskins maneuver just involves her on all fours, kind of crouching on the ground with her bum up in the air, as so, and it just gives you a little bit of a different angle to work with. This maneuver is it's not entirely sure how it actually works, but it can, just the movement itself, dislodge that shoulder. But here we're going to try to deliver the posterior shoulder. That from this position, that's what you would try to do. So some gentle downward axial traction, and you're just trying to deliver it. But if again, this doesn't work, then you just want to dislodge that posterior shoulder, and then once that posterior shoulder is out, it's happy days. But that's not going to be the case today. So we'll go back to this here. Okay, 30 seconds of this position, and then just doing that downward axial traction. Hopefully you should see some resolution and delivery to posterior shoulder. If that position is still not working, we go back to we can go back to our normal position, and this is when we move on to our internal maneuvers. First internal maneuver we'll move on to is the Rubens 2 maneuver. So that involves sliding 2 fingers just at the side of the baby's head here around to the neck, and just up here until we get to the anterior shoulder. When we're at the anterior shoulder, we just want to try and push this in that direction. Try and dislodge that again in time with the contractions. Yep, perfect. And then the baby should come out as so. Perfect. As we've seen just there, that Rubens 2 maneuver was successful and resulted in the delivery of the baby. We're going to show you now what happens when Rubens 2 is not successful. So we move on to what's known as the Wood's screw maneuver, and it involves 2 fingers here on the right hand in the same position as they were for the Rubens 2 maneuver. Slide them in here at the anterior shoulder, and then hold on, Connor. And then you want to put these other 2 fingers, try get them on the opposite side of the posterior shoulder, and you just want to push in turn. Perfect. Just to dislodge that shoulder. It's out. Keep pushing. There you go. You're doing a great job, man. Perfect. And then that results in the delivery of another baby. If for whatever reason that maneuver is not successful, we can implement what's known as the reverse wood screw. So we would then we would keep the same hand. So the right hand is always on the right hand side. The left hand is always on the left hand side. So your fingers that would be in there, you then don't take them out, but instead you move them downwards to the posterior shoulder, and the left hand, you move your fingers upwards towards the anterior, and you just push in the opposite direction to try and result in a delivery. If the reverse wood screw does not work, there's one more technique that we can try to deliver this baby successfully, and that involves removal of the posterior arm. There is some research out there that should be the first maneuver attempted when you're moving on to internal maneuvers. But here in Queensland, we use that as a last resort sort of maneuver, and we work through the Rubens 2, wood screw, the reverse wood screw, eventually getting to the removal of the posterior arm. So the baby is still restituting against the mother's perineum like so. We go in, still just kind of supporting that baby's head there. We want to find the posterior arm, and we want to just flex it across the baby's chest and just deliver the arm like so, which kind of lets the anterior shoulder move, and the baby is delivered. There is other research that's just recently been completed, and it took place in New Zealand. RANZCOG, the Royal Australian College of Obstetrics and Gynecology, have also kind of endorsed this maneuver, and it's known as auxiliary traction. A lot of clinicians when delivering a baby may have actually inadvertently done this maneuver when they're doing the posterior arm, but it involves getting your thumb and your pointer finger and wrapping them around the axilla of the posterior shoulder, and then having your middle finger pressed against the side. It's kind of like you're sort of cocked the gun a little bit, and you want to pull the baby along with some gentle traction on the birth canal and just up and out. It is shown to be a lot more successful as an initial first maneuver, internal maneuver, and should be probably initiated instead of the Rubens 2 or the posterior arm removal as the first internal maneuver. It reduces the time of shoulder dystocia quite significantly and does not have any increase in maternal or fetal injuries doing so. So we're going to demonstrate it here. So you can just gently, with some axial traction to the baby's head, we'll go in here with just grabbing the axilla, and we'll just kind of pull